Good morning. Um, Thank you very much for having me as part of your symposium. So I'm actually going to talk about neurological research and the opportunities and the challenges that are associated with doing neurological research. So I think like any opportunity in life, there are always things that are considered as opportunities or positives, and there are challenges that may actually appear as negatives. So when I look at the question of neurological research, I think that perhaps some of the things that are positive are highlighted in green. So there's obviously interest. That's why we are having this conversation. There is a large number of patients that the OIC as a group does see. There's a large number of research staff, and the cost of doing research is actually low. However, there are certain negatives. Perhaps the knowledge level may not be there. Although there is a large number of patients, but perhaps the number of research capable centers may be actually low. Centers that actually can perform research and not just manage patients or perform clinical care. One of the challenges I see is always that there's a lot of clinical responsibility. So obviously then it takes limited resources and limited effort that's left for clinical research or research in general. And again, the funding opportunities are limited. Research does cost money. And essentially, in the absence of a sustainable research funding, it is hard to actually continue research. So, well, one would think that these are the limitations, and perhaps other countries, the United States, do not have challenges. But I think that perhaps we need to look at a closer look and understand that challenges exist everywhere. So I think that yes, perhaps there is more interest. Perhaps there is a knowledge base and infrastructure in place. Perhaps there are funding opportunities that are greater, but there's a limited number of patients. There are multiple trials going on for the same group of patients. And the research staff is actually low. Research staff is very expensive and is hard to maintain. So there is actually a limited number of resources that are available for research. Surprisingly, yes, there is a large number of hospitals in the United States, over 5,000 hospitals. But actually, if you look at the hospital that are research capable centers, that is surprisingly pretty low or very low in the United States. And clinical responsibility is an issue everywhere, even in the United States. There's a constant challenge between clinical responsibilities and time and resources allocated to research. However, if you look at the productivity between the two scenarios, there is a marked mismatch between the amount of research that's to be done in United States as compared to other countries. And actually, I want to clarify that there are other countries that have done better than the United States or continue to do better. I think that there's an emergence of more productive research in China and Europe now. So I think the scenario is actually changing. But I think that there are two unique challenges that we have to acknowledge. I think that there is not a clear reward for doing research in many countries, and perhaps the OIC countries. And I think there's also a lack of spirit of working as a group. I think we all perform exceptionally well as individuals, but perhaps not so well in working as a group, which seems to be an essential element for conducting successful research. So I think that at some point we have to strengthen the weaknesses if you're going to look at these neurological research opportunities. And essentially, the only way to strengthen these resources would be to actually do work, actually do clinical trials, and work through clinical trials to strengthen some of the gaps that we have seen or have identified in the previous slides. Now, I want to actually say that perhaps the start shouldn't be a complex clinical trial. It should be a simple, pragmatic clinical trial. And actually, surprisingly, that's where research is moving. Even in the United States, there is actually increasing emphasis on doing simple, pragmatic clinical trials because it seems like the yield is much higher, the cost is much lower, And in the end, the impact to society is far more favorable with pragmatic clinical trials than more complex, sophisticated clinical trials. What does a pragmatic clinical trial really mean? I think it probably is the intervention is simple. And if you look at the intervention that have really made a difference, for example, let's take patients with stroke and the outcome of patient with stroke. It has not been the most sophisticated interventions as mechanical thrombectomies and intravenous thrombolysis. It has far been standardizing care in stroke units and simply taking some basic steps to improve the overall quality of care for these patients that have probably made the greatest impact than more sophisticated interventions than mechanical thrombectomy and intravenous thrombolysis. Conduct is simple. So instead of a more sophisticated design, it actually is a more simplistic design. And with limited data that is collected, I think that there is a recognition, even in the United States, that trials have been trying to collect a lot of data that in the end doesn't really play or doesn't really add to the scientific question or answering the scientific question. And there is a large amount of data that's collected that is never even analyzed in clinical trials, or not analyzed to its fullest potential. So I think that perhaps our focus, if we're going to move forward, should be a simple, pragmatic clinical trial. For example, I want to work with an example, and this is something that I've been working with Professor Wasev, intravenous fluid therapy for stroke treatment. Now, there is almost 15 million people that have stroke worldwide every year. Intravenous fluid is used in approximately 14 million people, stroke patients, every year. That is 100 times more than intravenous thrombolysis or mechanical thrombectomy will be used in stroke patients worldwide. And now we also know that if you look carefully, existing intravenous fluids have high chloride content and perhaps low osmolality, both of which are actually associated with an increase in death and disability after stroke. And there is room to actually improve upon that, perhaps develop an intravenous fluid that actually is chloride deficient and has the best composition, and that may actually make a much bigger impact on reducing death and disability after stroke than perhaps more sophisticated intervention. And actually, if you look at patients with intracerebral hemorrhage, and actually look at those patients who develop hyperchloremia, so an increased chloride content, something that we've always ignored, and who has ever actually cared about chloride content and chloride composition or chloride levels in patients with stroke? But actually, if you look at patients with intracerebral hemorrhage and actually look at mortality at 90 days and death or disability at 90 days, patients who actually have no hyperchloremia and compare them to those who actually have one occurrence of hyperchloremia and two or more occurrences of hyperchloremia, and again, hyperchloremia being defined as a serum chloride level of 110 millimolar per liter or greater, there is a significantly higher rate of death and significantly higher rate of death and disability at 90 days in patients who actually have multiple episodes of hyperchloremia or even a single episode of hyperchloremia. And this is actually after adjusting for all the other known predictors of outcome in intracerebral hemorrhage. So surprisingly, something as simple as an electrolyte imbalance like hyperchloremia can make a big difference on patient outcome. And that is not just limited to intracerebral hemorrhage. You see the same effect in ischemic stroke. So if you analyze the data from the ALIAS 1 and 2 and actually look at patients with ischemic stroke and look at the rate of death and disability at 90 days, and actually look at one occurrence of hyperchloremia and then two or more occurrences of hyperchloremia, and even after adjusting for the known covariates of age and the National Institutes of Health stroke scale, there is a significantly higher rate of death and disability in patients who develop two or more occurrences of hyperchloremia. And you can actually see the odds ratio is 2.7 with a confidence between 1.7 to 4.2. So again, not just an intracerebral hemorrhage, but even an ischemic stroke, high chloride or occurrence of hyperchloremia actually increases the rate of death and disability at 90 days. Now, actually, it's also important to recognize that most of this hyperchloremia that we are seeing in these patients is introduced by the patient with the intravenous fluids that we're giving. We're giving them a large content or large amount of normal saline that actually perhaps has a sodium chloride that's a little bit higher than serum chloride, but definitely much higher chloride content than compared to the serum chloride content. So we could actually simply do a simple trial, a seamless phase 2, phase 3 trial. We'll actually look at intravenous fluid that's more appropriate and compare it to the standard intravenous fluid in patient with acute stroke, which includes patients with intracerebral hemorrhage and those with ischemic stroke, and take them within 12 hours and start an intravenous fluid that usually will be continued up to 72 hours and look at the outcome at 90 days. It's seemingly a simple intervention, a simple design. And obviously we need to find what is the right fluid to be used in the clinical trial, which we call as a phase 2 dose finding study. We need to do a phase 2 futility study with a larger number of patients to actually see that there is at least an early signal that the death and disability will be lower with reduction of hyperchloremia. And then if all of these pieces add up, actually do a phase 3 efficacy trial where actually you're comparing the standard intravenous fluid with a new intravenous fluid that supposedly avoids hyperchloremia and making or assessing whether it reduces the rate of death or disability. So the first part could be simple, which is what is a dose finding study, where you usually take multiple doses. In this case, it will be multiple compositions of intravenous fluid to determine what fluid actually reduces the incidence of hyperchloremia. So the outcome is very simple. Essentially measure serum chloride for the first 3 days and find out the fluid that actually results in the lowest incidence of occurrence of hyperchloremia. You have sodium chloride, which is the standard fluid today in most places. And then you actually can use a mixture of sodium chloride and sodium acetate. So essentially you're not giving up on the sodium content, which actually seems to be important and beneficial for maintaining serum osmolarity that's favorable for the brain. But you are giving up some of the chloride content and replacing it with acetate. Now we don't know what mixture would be best. So it could simply be a 3-to-1 ratio. It could be 2-to-1 ratio, or it may actually be 1-to-1 ratio that may be the best suited. So essentially we will be trying 4 different fluid compositions or 3 different new fluid compositions against sodium chloride to determine which one can actually provide us the best results when it comes down to avoidance of hyperchloremia. Once we make that selection, then we go to the next level where we have taken the normal saline, which is the standard fluid, and now we're actually comparing it to a combination of sodium chloride and sodium acetate. And whatever that ratio we have actually selected in basis of dose finding study, and now we're actually doing head-to-head comparison. Now the phase 2 futility study usually is not powered to actually show a statistically significant difference between the two groups. But it actually is powered to show a meaningful difference, a difference that would be compelling enough to actually move to a phase 3 trial. Because if in the initial analysis you're not even seeing a signal, not even a hint that this actually could be beneficial, it doesn't make sense to actually go through phase 3 large trial, large number of patients are recruited when the early evidence was not even supportive of actually moving to a phase 3 trial. And this interim step has been added, which we call as a futility study, but perhaps again trying to determine whether it's even futile to actually go to a phase 3 trial. And then if you actually make it to a, gone through the dose finding study, you've gone through the futility study, then one can actually move to a definitive study where you're actually combining or comparing sodium chloride, which is 0.9%, and actually comparing it to a combination of sodium chloride and sodium acetate. And whatever that ratio was selected in the dose finding study will actually move to the final phase 3 study. And the primary endpoint is death and disability, or death or disability at 90 days after randomization into this trial. So there's not a lot of information we need to collect here. There's not a very complex set of intervention that will be required. These intravenous fluids can be performed or prepared by local pharmacies. The cost of intervention is very cheap. Making normal saline in a local pharmacy and making a combination of normal saline and sodium acetate is really not a very expensive effort. And collecting 90-day outcomes in all of these patients is effort, but effort is not a significant amount of effort when research staff and research resources are relatively cheap. So I just bring this trial as an example because at some point one needs to actually take a starting point. It doesn't have to be a trial like this, but obviously there are trials like this that actually have simple interventions, limited amount of data collection, and yet can make a big difference in a large number of patients worldwide as compared to more sophisticated intervention, which even in the United States are only applicable to a much smaller group of patients. So a neurospecific intravenous fluid is perhaps the best therapeutic that can be made widely available. A neurospecific intravenous fluid has applications in traumatic brain injury in addition to stroke. So it actually has a much broader implication than in addition to stroke. Now many of you may not know the history of normal saline. And normal saline was first introduced in 1830s. And the first place that actually introduced was British India. It was actually introduced for treatment of cholera. And the second time sodium acetate was introduced was again in Pakistan, actually for cholera, again for volume depletion. So the history of these fluids actually is in Indo-Pak. It's not in Europe, it's not in the United States. So perhaps this is an ideal time to take it to the next level of something that it already has its origin in the Indo-Pak region. So how do we actually take these neurological opportunities and overcome these challenges? I think the answer is simple. We've got to start somewhere. It may not be the ideal place, but it has to start somewhere. And we have to learn along the way. And only then we will be able to bridge some of the gaps that we have in terms of knowledge, in terms of actually having research capable centers, in terms of actually creating enough initiative to actually overcome the clinical responsibility. And perhaps we have to work together to find these research funding. We don't need a lot of research funding. Obviously, we need some, but there has to be some local support that will allow us to move forward. And I think that in the end, I still want to highlight the importance of working as a group. I think a small number of people carrying a large baggage is very unlikely to go far, definitely not going to finish the journey. In opposed to and in contrast to a large number of people carrying a small amount of load, which definitely will take us to the finish of the journey and would perhaps have a reward for everybody when the journey is completed. I'm going to conclude there with these particular statements. I hope that these statements and I guess these observations may be of value as we explore neurological opportunities and overcome some of the challenges that currently face us. Thank you very much.